Okay, thank you, Rhonda, for starting that off. So we'll look at today's agenda. And so this is what we're going to be focusing on for the morning today. Again, we're starting with a bit of a hello and a welcome. We're then going to spend some time while I'll be reviewing an overview of the Central South Regional Stroke Network, a bit of a provincial and regional organization of stroke care. And then we're going to be looking specifically at how all of the data informs best practice implementation, quality improvement, as well as funding. And so we really want to ensure there's a clear understanding of how accurate data is so important to funding and best practice implementation. And then, as I mentioned earlier, Rhonda and Debbie will really take over the rest of the workshop for the morning, looking at specific things like our special projects, CHI 340, 640, 740, as well as some of our transfer models through the region of where patients will move throughout our region. And then we'll look at cases in relation to both of those areas of specialization. At the end, we'll have some strategies shared to improve special project data quality. And then Rhonda is going to finish up the morning by looking to the future, some future directions of stroke care and where we're heading moving forward. So we hope it's an excellent day. We appreciate you taking time, and we'll get started now with the first presentation. So as I mentioned, I'll start today by giving a little bit of background on the provincial and regional organization of stroke care in Ontario. We'll go to the next slide. The objectives for this section of the agenda are as follows: to describe the provincial and regional structure and best practice implementation in the province and in our region, to provide a high-level review of our regional models that impact stroke care, and you may see within our documentation throughout the region. We'll be looking at our hyperacute stroke care models, our bypass models, the utilization of telestroke within our region, acute stroke unit transfer models and how we access acute stroke unit care within our region, and then stroke rehabilitation sites, knowing where they are within our region and how we're utilizing them. And then we'll have some time for questions and discussion before we jump into the next section of the morning. We'll go to the next slide. So in about the year 2000, the Ontario stroke system was developed, and you can see that here on the slide. The OSS, as it was called, is a system of regional stroke networks that were developed to organize stroke care delivery across Ontario. So the province, as you can see here, was divided into 11 regional stroke networks with a regional stroke center and district stroke centers in each. Each of the regional stroke centers and district stroke centers are required to meet designated guidelines and provide what is currently accepted as the gold standard in acute stroke care. These designated sites have additional roles, including a regional role in organizing the human and medical resources for their region and for developing a regional plan across the continuum of care. Regional stroke centers also have the responsibility of providing leadership for growth and development of the OSS for their region in partnership with all of the district stroke centers, as well as community hospitals, community systems, and other key stakeholders. We'll move to the next slide, Rhonda, and we'll talk specifically about the Central South region. So what we're seeing here is the entire Central South region. Central South Ontario consists of the previously named LHINs 3 and 4. And so those were the Waterloo, Wellington, and HNHB LHINs. We now know that these names have changed as the LHINs no longer exist, but this is the part of the Ontario West region that the Central South region is responsible for and accountable for. Within this region, we have many teams that work every day to deliver best practice care for those affected by stroke. Highlighted on this diagram, it's kind of small to see, but in black and red, you can see the Hamilton General Hospital as the regional stroke center, and also our 3 district stroke centers. The district stroke centers within our region are the Greater Niagara General Hospital, the Brantford General Hospital or Brantford Community Healthcare System, and Grand River Hospital. In our region, we also have additional thrombolysis delivery sites at the Guelph General Hospital and Joseph Brant Hospital. Within the region, there are also 6 acute stroke units and 6 stroke rehabilitation units. And additionally, you can see here there are 22 hospitals listed We work with all 22 hospitals and numerous organizations and agencies like our paramedic partners, the March of Dimes, Heart and Stroke Foundation, all together to improve stroke care across our region. Okay. And so if I was to boil it down into really one sentence, the mandate of the Regional Stroke Network is to facilitate the implementation of stroke best practices across the entire Central South region and across the entire continuum of care. This is inclusive of everything within the diagram you can see there flowing at the bottom of the screen. Public awareness, ensuring the public is knowledgeable about what stroke is and how to react to it. Stroke prevention, our clinics and strategies. Hyperacute care, as we've talked a little bit about, and we'll talk more about it in a minute. Acute stroke care, and stroke rehabilitation and community reintegration across our region. And so this is the regional and district stroke team. And there's representatives here from the Stroke Center in Hamilton, as well as all of our district centers in Niagara, WW, and Brant Haldeman, Norfolk. As you can see, it's a small but very mighty team with specialists in acute care, rehabilitation, education, and leaders at all of our district sites to really drive best practice implementation cross region and cross geography. Okay, so that's a bit of background as to the structure and organization of stroke care within the province and then within our Central South region, and a bit of insight into the team of the Central South Regional Stroke Network. So now I'll switch focuses and look a little bit more at specific plans of care. And so first I'm going to look at the hyperacute stroke centers. And so we thought it would be helpful to visualize the hyperacute stroke access within our region. As a reminder, when referring to hyperacute stroke care, we're primarily speaking to the delivery of thrombolysis, whether it be TPA or TNK or tenecteplase, and or performing endovascular therapy. And I just wanted to quickly define endovascular therapy here, because I'll probably refer to it as a few different things in the coming slides. Endovascular therapy is sometimes called clot retrieval, and as an acronym, it can sometimes be called EVT. And so I want to make sure that everyone knew that if I say any of those things, I'm referring to the same thing. Thrombolysis is delivering a drug that helps dissolve clots that are causing strokes. And endovascular therapy, or EVT, is an actual procedure where the clot is physically removed to restore blood flow to the brain. We could spend the whole presentation on those two pieces, but just as high level, that's what we're referring to. So we'll go to the next slide. And this is a map. And so as you can see here on the map, Ron, if you hit the next slide, it'll show a diagram here. It'll show circles. And again, so there you can see the centers circled on the map who provide hyperacute therapies, again, whether it be thrombolysis or endovascular therapy. Within our region, we briefly talked about this earlier, but there are 6 thrombolysis delivery centers. So those are Grand River Hospital, Guelph General Hospital, Brantford General Hospital, Joseph Brant Hospital, the Niagara General Hospital, and the Hamilton General Hospital. The Hamilton General Hospital within our region is the only endovascular therapy or clot retrieval center within the region. So every EVT case from all of our regional hospitals are transferred to the Hamilton General for endovascular therapy. There is a backup system in place, and if for any reason the Hamilton General is not able to accommodate a case, so for example, if we were in a downtime for some reason, there is a provincial system in place where potential EVT patients would be referred to what we call an R2 center or a backup EVT center. So in our area, if we did require the utilization of an R2 center, depending on where within our geography the referral comes from, we would either refer to London Health Sciences or to Trillium Health Partners, either to the east or west of us. So we'll go to the next slide. And we'll talk a little bit more about hyperacute stroke care, but looking specifically at our bypass models. And this is in the 0 to 6 hour window from the onset of stroke. And so we thought it would be helpful to review our local bypass models. And so in those first 6 hours after a stroke, the paramedics will actually bypass non-stroke hospitals to bring a patient to a hyperacute stroke center. And so what we have on the screen here, this is the actual acute stroke bypass protocol. If patients present with a new onset of at least one symptom suggestive of the onset of an acute stroke, so this could be anything like arm or leg weakness, slurred speech, inappropriate words being utilized, unilateral face droop, basically any of the FAST signs. The onset of the symptoms is clearly determined. The patient is then transported to arrive at a designated stroke center within the 6 hours of the time of symptom onset that the patient was last seen in a usual state of health. So just to illustrate this with an example within our region, maybe we can take the example of Dunnville. So if a patient is picked up in Dunnville by paramedics and determined to be within that 0 to 6 hour window of stroke symptom onset, the paramedics will actually bypass the closest non-stroke hospital in Dunnville and transport the patient directly to the Hamilton General Hospital for hyperacute stroke workup and treatment. Conversely, if a patient was to present to an ED at a non-stroke center within that 0 to 6 hour window, those patients are immediately transported by lights and sirens to the nearest stroke center for potential treatment. So we'll go to the next slide there, Rhonda. And so this map here is meant to grossly show the patterns of transport for patients who are within that window within our region. And so you can see here that areas with non-stroke hospitals or non-stroke specialty hospitals are clearly bypassed to get to the designated stroke centers for immediate stroke workup and treatment. And so this model is really put in place to ensure that any patient found to have stroke symptoms within that time frame get immediately to a stroke center. We did want to touch on telestroke just briefly within this presentation. And so telestroke is an incredible system that allows centers without access to stroke neurologists to access stroke neurologists on call 24/7 for hyperacute stroke consults. So we'll go to the next slide, Rhonda. And what this diagram is meant to show is the connection between a remote or community emergency department via a secure video conference with a stroke neurologist. And that stroke neurologist is able to quickly come online, virtually assess the patient, review images, and facilitate decision-making regarding the delivery of thrombolysis and or referring that patient to the nearest endovascular therapy center as quickly as possible. We'll go to the next slide, Rhonda. And so as you can imagine, this has some clear benefits. Included in this are that it allows, as we said, for access immediately to stroke experts despite distance. The distance doesn't matter because it is done by video. This also decreases the need for patients transferring to another hospital and losing time before treatment can begin. It allows that assessment to be done by a stroke neurologist immediately on site where the patient is. An incredibly helpful system. And so on the next slide, we'll show how we utilize this within our region. We can see here the sites that are circled in red, Brantford, Joe Brant, and Guelph, are all 24/7 users of telestroke, a telestroke model. Those centers that have purple circles around them, Grand River Hospital and Niagara General Hospitals, are centers that use telestroke during certain times, whether it be certain times of the day or as needed. So they use them, we sort of say as PRN, as needed and required. Currently, just for our awareness from a data perspective, the province is focusing on a bit of a data gap they're seeing in the number of telestroke activations reported at a site level and those reported from a provincial level. And so they're looking at understanding why there's a gap in those data points. And the province is trying to better understand this data gap and correct it to get a better a better understanding of the utilization of telestroke within our region across the province overall, so we can plan better for it in the future. So now we'll talk a little bit about EBT access models. And so we'll just spend a minute or two on this, and we'll go to the next slide. I've covered this a little bit in a previous slide, but EBT referrals primarily go from our thrombolysis centers to the Hamilton General Hospital. That system is currently built in our region that has patients who may be potential candidates for EBT get to their closest stroke center as quickly as possible, where they can be further evaluated for potential EBT and referred directly to the Hamilton General Hospital quickly for that procedure. Very rarely would a non-stroke center send a patient directly to the Hamilton General Hospital for clot retrieval. What is also of note, and we'll share this a little bit more detail on the next slide, is that for endovascular therapy, there are early and late treatment window protocols to determine who is eligible for it. So unlike thrombolysis, the window to provide EBT can be up to 24 hours when appropriate diagnostic and assessment is completed. So we'll go to the next slide, Rhonda. And so if a patient is found to be having a stroke in the early window, and so what we mean by early window is the 0 to 6 hour window, the paramedics will utilize the bypass protocols we spoke to get a patient to a stroke center ASAP. Once there, the patient will have an imaging protocol that includes a CT and multi-phase CTA. In the expanded window of 6 to 24 hours, a patient is brought to the nearest hospital as quickly as possible, and we've worked with all hospitals in our region so they can do appropriate assessments and recognize potential expanded window EVT candidates. They would link to their nearest stroke center, and get eligible patients there as quickly as possible. Once at that stroke center, the patient will undergo a different imaging protocol of a CT perfusion, and CTA. This protocol also includes the utilization of rapid software. So I'm sure some of you have heard of what rapid software is, but rapid software is an automated software that can determine a patient's brain determine the amount of salvageable brain tissue for a person who is currently having a stroke. And they can determine whether that patient would potentially do very well with endovascular therapy in that expanded window. This technology has been a true game changer across our region, and we're very proud to say that Central South is the only region in our province that has a hub and spoke model to ensure that every stroke center in the region has access to this software. So we'll flip to the next slide there, Rhonda. Thank you. And we'll talk a little bit about acute stroke unit care models. So on the next slide, we'll see that really the foundation of much of the work we do starts with ensuring that persons with stroke have their treatment on a dedicated acute stroke unit. So next slide, Rhonda. We know that treatment on a stroke unit is as effective, if not more effective, than many medical treatments within stroke care. We also know that from the evidence, stroke unit care, so being treated on a dedicated acute stroke unit, reduces morbidity and mortality of stroke by about 30%. And we also know that there's significant increase in the likelihood of being home 1 year post-discharge rather than requiring institutionalization. In past years, the region has implemented many models of stroke integration across the region to ensure everyone can get access to stroke unit care. And I'm very pleased to say that we now have in place a model or protocol for all centers within our region to ensure that they deliver stroke unit care and or have a process to access stroke unit care as quickly as possible from any site within our region. So as one of the last parts of the first presentation here this morning, we just wanted to also focus on the importance of stroke rehabilitation and stroke rehabilitation sites within our region. So if we go to the next slide, again, utilizing this map that we've kind of used to demonstrate our models across the region, this outlines all of the stroke rehabilitation sites within our region. And so as you can see, they're spread through our region, ensuring great access across Central South to excellent stroke rehabilitative care. The sites highlighted here are a mixture of standalone stroke rehabilitation sites and integrated stroke rehabilitation sites. And so highlighted are Freeport as part of Grand River Hospital as a standalone site, St. Joseph's St. Joseph's Healthcare Guelph, Hotel Dieu Shaver, and the Regional Rehab Center at Hamilton Health Sciences. Those are standalone rehab centers. It should be noted that at the Regional Rehab Center in Hamilton, there is a bridge connecting the acute stroke unit and the stroke rehabilitative unit from the acute part of the hospital to the rehabilitative rehab center. Highlighted at numbers 5 and 19 are Joe Brant and Brantford General Hospital. These are two integrated stroke units within our region. So what that means is literally the units are divided in half, where half of the unit's beds are dedicated to acute stroke unit care and half of the unit's beds are dedicated to stroke rehabilitation. But with this map, there is assurance that patients across our region will get access to great stroke rehabilitation at any of these sites. So we'll take a little pause here. I'm doing the next presentation as well within this morning's agenda, but if there are any questions about our models, whether it be for hyperacute access, telestroke, acute stroke unit access, or rehab, happy to take those questions now. not seeing any questions. You please put them into the Q&A function at the bottom of your screen. You'll see an option for Q&A. So if you do have a question, we'll just give it another 30 seconds. Rhonda, Debbie, any questions from you? Are we all okay?
No,
Good.
none from this end.
Good.
Okay. Okay, well, hopefully that means that the presentation was very clear and all of our models are very clear. And hopefully that provided a basis of understanding of how patients move within our region, where they're accessing their stroke care from all parts of the continuum of care. But we really try to build a collaborative network of stroke best practice implementation across our region so that any door a patient enters, they'll receive excellent stroke care. Okay, if there are no further questions, we can move to the next slide, Rhonda, and that'll be the next presentation. And so the first part of this next section will look at how funding reform has occurred in our province, and we'll focus a little bit on the QBPs as well within this section. So we'll go to the next slide there, Rhonda. And I did want to make a note here before jumping into this. I did want to give credit to Ellie Wisniewski for the upcoming slides within this presentation. Ellie and I did this part of the presentation collaboratively last year, and the next few slides were ones that she led. So thank you very much, Ellie. We're going to spend the next few minutes really looking at how stroke data drives best practice, quality improvement, and funding within our region. So we'll go to the next right there. That's great, Rhonda. So healthcare funding has moved from global funding, which is a historical approach where health service providers received lump sum funding, through health system funding reform, which is an evidence-based approach with incentives to deliver quality-based care based on the number of patients, services delivered, best practices, and the needs of that population. So if we go to the next slide, there's a diagram here that helps describe this. As the health system went through funding reform, the budgets were broken down into 30% global funding, as previously utilized, and 70% patient-focused funding. The patient-focused funding is based on the patient population and reflects the disease, diagnosis, treatment, and acuity of that clinical cluster. Patient-focused funding is broken down into 40% health-based allocation method, which is HBAM, and 30% QBPs. HBAM is a methodology that determines funding based on patient demographics, clinical and financial data, whereas QBPs are evidence-based targeted quality of care clusters that will be allocated funding based on an equation of price times volume. So if we go to the next slide, this is really demonstrating the importance of accurate coding. And so it's clear based on those funding models that the coding accuracy has a significant impact on funding. And so really coders tell the patient's story by converting clinical documentation into standardized codes. It's from this coding that RIWs and HIG weights are calculated to inform the HBAM funding model. It's so clearly important. And if we go to the next slide, focusing on QBP, when it comes to QBP funding, again, coding remains incredibly important as certain clinical handbook stroke categories are included in the QBP funding approach. Once there are those categorizations completed, the equation that we talked about earlier of a fixed price times volume of cases is really used to determine that QBP funding amount. So it really speaks to the importance of coding related to funding within our region and beyond. And the last part I'll review here, and then again open it up to questions, is really focusing on how data is used as the basis of quality improvement throughout the Central South region and for all of our stroke hospital organizations. Our goal as a region is to always and continually improve stroke care through the Central South region. So this is extremely important to our work. All of this leads to improved patient outcomes for patients with stroke in Central South Ontario. So what I'll review is the impact of data on quality improvement in our region, and then look specifically at key data utilizations, looking at stroke distinction, looking at the annual stroke report that's released by the province, and then really narrowing it down to a local focus and talking a little bit about our regional stroke monitoring and evaluation committee. So the process for quality improvement strategies regionally begins with the analysis of current state, which requires fulsome data analysis. The evaluation of quality improvement strategies utilizes data to ensure implementation has been successful and has had a positive impact on patients. All quality improvement really begins and ends with the need for accurate data and has significant impact on persons with stroke within our region. So if we spend just a minute here talking about stroke distinction, and this is a program through Accreditation Canada that focuses on stroke best practice implementation at centers. If we go to the next slide, Rhonda, in November of 2019, Hamilton Health Sciences had their third site visit for stroke distinction accreditation, and they achieved stroke distinction in both acute and rehab streams of service. Every 4 years, Accreditation Canada has a site visit in order to evaluate processes and best practices at those sites that are part of the stroke distinction program. And data, as you can imagine, plays an essential part of the quality improvement strategies that go along with stroke distinction accreditation. Key metrics are used to indicate improved and sustained performance, leading to better patient outcomes. Data helps review targeted areas that perhaps are not meeting Accreditation Canada standards and need improvement. Data allows us to track our progress as we move towards distinction accreditation. Numerous indicators are required from across the continuum of care, from acute care, rehabilitation, and beyond. We also are required as part of stroke distinction to choose optional indicators to report on. And so again, mining the data to look for those indicators. In between the site visits, sites who go through stroke distinction are actually tasked with reporting data to Accreditation Canada every 6 months. So the data submission is not just at those site visits, but every 6 months in between site visits as well. And so data is the key to the process and maintenance of high-level standards in achieving stroke distinction for the sites that move forward with it. The example discussed here is really focused on the Hamilton General Hospital, but potentially in the future, more sites within our region will go through stroke distinction, and excellent quality data is essential in us understanding the current state, quality improvement strategies, and targets, and helps us sustain our improvements, which lead to better outcomes for our patients. The next piece of provincial data we'll speak to is the annual Core Health Stroke Report. So every year, Core Health Ontario releases the stroke report, and I'm sure many of you have seen this report. Years ago, it used to be in the form of a report card with yellow, green, and red utilized. This stroke report pulls data from multiple sources to create a cross-continuum evaluation of current performance. The report focuses from hyperacute data to acute data, rehabilitative data, and even into the community aspects of care for persons with stroke across Ontario. The report pulls data from a provincial perspective, a regional perspective, and then it even sends data organization by organization. And so this data is crucial as it's a driver for change in stroke care across the province. This data utilization is moved forward for organizational priority setting and meetings we have with each organization across our region. And it's also used for our regional strategic planning in terms of best practice implementation across Central South Ontario. So the data that they are pulling from our sources, so incredible in terms of the importance of its accuracy to really develop those best practice implementation strategies and identify those opportunities for improvement, and also to celebrate our successes as well. And finally, today, I just wanted to focus a little bit on a committee we have in our region that looks at specifically at stroke performance metrics based on a quarterly basis. This committee is called the Regional Stroke Monitoring and Evaluation Committee. And what this committee does is it looks at the indicators which I've listed here across the continuum of care, inclusive of the entire continuum, looking from hyperacute straight through to the community, stroke rehabilitation, and even to complex continuum care and long-term care admissions from our region. This meeting is utilized to determine key successes regarding stroke performance in the region so that those centers who have achieved those successes can share their strategies for success, and hopefully those strategies can be taken up by other areas within the region so we can build collaboratively together that achievement of stroke best practices. Just as well, areas for opportunity of growth on the RSMEC report card can often stimulate regional discussion on how to improve those metrics and in turn improve patient outcomes after stroke. This is such an incredibly important table to quality improvement and best practice implementation within our region, and it's all based upon excellent data. My apologies for the slide being small. Maybe we can send out something different at the end, Rhonda, sort of with the package that goes out so that these can be shown more clearly.
And Steph, I don't know if maybe just you quickly review the indicators for people very high level, what they are, because as you say, it is a bit small on the screen.
For sure, yeah, absolutely. So it really look from, I'll go through most anyways. We look at things like the proportion of patients arriving at hospital by ambulance. We look at the mortality rate at each of our centers. We look at the proportion of patients who have been prescribed medications for atrial fibrillation, looking at antithrombotic therapy. We look at the proportion of patients who receive carotid imaging. We also looking at our hyperacute processes. We look at the door to needle time, so the amount of time it takes from a patient who gets to the door until those who receive thrombolysis actually have the drug delivered. We also look at the proportion of patients who receive thrombolysis. Moving into the acute phase of stay, we look at the proportion of patients who are accessing stroke unit care. We look at the proportion of patients those who are discharged directly from our EDs with the TIA, how many of those patients are referred to stroke prevention services. So as you can see, it's kind of cross continuum there. We look at ALC days. We look at the proportion of patients who go from acute care to rehabilitation. And then once in rehabilitation, we look at achieving targeted length of stay. We look at the number of days it takes to get from acute care to rehabilitation. So we call those onset days. We look at the actual number of minutes that patients receive in stroke rehabilitation on a daily basis. So we call that rehabilitation intensity. We also look at things like FIM efficiency, so the amount of change in a functional independence measure over time. And then we also look at the proportion of patients with severe stroke accessing rehabilitation, and then the proportion of patients who are then who access complex continuing care or require referral to long-term care. And finally, readmission rates are also looked at in this committee. In addition to this report card, we also have report cards that are shared from our community partners, and we look at our two large best practice-based community stroke rehabilitation models and look at performance metrics through those models. And finally, we also utilize the IDS, and so I'm sure many of you online are very familiar with the IDS. We use the IDS to review further data to ensure we have a good understanding of our current performance and where there's opportunity for improvement, and again, to celebrate our successes. Sorry, I know that was quick and there's a lot there, but I hope that this has given a good overview of some of the work of the Central South Regional Stroke Network as we use data really as the foundation of our quality improvements. And really, this is what leads to us being able to implement strategies that lead to better patient outcomes, which is of the utmost importance. So I thank you for your time. I hope this was really helpful. Again, happy to take any questions. Again, and please use the Q&A function. Not seeing any questions. I will be here for the remainder of the workshop today. So if any questions come up, please feel free to send me a message or send me an email. Happy to answer any questions. But maybe with that, Rhonda, I can hand it to you for the next part of this morning's workshop.
Thanks, Steph. Oh, Steph, looks like there's a question in the Q&A. How would it take to access EVT from Niagara? Oh,
So,
hold on.
yeah, so I think what the process in terms of the outline is that assessment happening rapidly at those centers within Niagara. We have a system in place where those patients who would require EVT would connect very quickly with Hamilton as the only stroke center within our region that performs endovascular therapy. And once that connection has been made, the evaluation has been made that the patient would be appropriate to move forward with endovascular therapy. The connection is quickly made and the patient is sent immediately and quickly from Niagara to Hamilton to undergo endovascular therapy. Rhonda, feel free to add into that as well.
No, that's good stuff. That's great. Yeah, it's a very quick process and a very streamlined process that we built with our sites.
Thank you for the question, Mary. Is telestroke the only method physicians contact on-call stroke physicians? So for telestroke sites, so the ones that use them 24/7, yes, that is the way in which they would primarily be reaching out in order to access stroke neurologist specialty in those hyperacute activations. There are backup models that we've built within our region, which I think are very important. Telestroke is an incredibly reliable system. It's always up and running, but in the very rare occurrence that there may be an issue with it, we've actually built in models within our region so that even if there couldn't be access through telestroke, we have a system where stroke neurologists on call within our region would then be able to be reached out to for any sort of urgent matters in that hyperacute time frame.
And certainly some sites have their internal stroke teams. So certainly telestroke is a model for sites that do not have their local stroke team, but those that do have their local stroke teams. So for example, in Niagara, they have their local stroke neurologists. At Grand River, a lot of the time that they do, they would contact their local stroke teams, and at the Hamilton General, if they have their local stroke teams, they have their mechanism where they would contact and page them. The team will come in and assess the patient, but those telestroke models are for those that do not have local stroke experts.
And so as a reminder, there's a slide earlier that shows the sites that are 24/7 sites, which would be Brantford, Guelph, and Joseph Brant. So the 24/7 telestroke sites, and then the as needed sites or on a scheduled sites, I guess you would say, would be Grand River and Niagara Health or Greater Niagara General Hospital. And Amy makes a good point here. Some sites may contact neurosurgery at HHS for hemorrhagic strokes. Thank you, Amy. That's a good point.
And that would not be so, but if we're contacting the Hamilton General for neurosurgery, that would not be considered telestroke. That would be consulting for neurosurgery. So just as a clarification, when we're coding sort of the telestroke model, it is primarily telestroke in the special projects. Okay, I think for the sake of time, we'll move on. Certainly, if there are further questions, staff can respond and answer them in the Q&A. And so I'm Rhonda Whiteman. I'm the clinical nurse specialist with the regional stroke team, and with Debbie's support, I'm going to walk through and review the special projects 340, 640, 740. Again, I recognize that as coders, you have the basis for this, so it really will be a review and highlighting some key points or changes that have been made. Again, I'm also going to, in addition, one of the things we heard from last year's workshop was post-admit strokes, looking at complications, sequelae of stroke and stroke risk factors. So I'll also talk about that as we move forward. So as Steph said, really the essence of the special projects were really to capture some of those key stroke best practices to allow for surveillance of the stroke care that we're providing, our quality improving and benchmarking, and very much in collaboration with the Heart and Stroke Foundation to measure those best practices. And many of them form the foundation of the Accreditation Stroke Distinction Program. So as you know, the special project codes need to be completed for ICD codes of the applicable conditions. So subarachnoid hemorrhage, intercerebral hemorrhage, cerebral infarction, not I63.7, stroke not specified as hemorrhage or infarction. Do want to flag that as a province, as stroke centers are really trying to minimize the use of coders having to utilize this code because we know that the majority of our patients do have a CT scan and really ensuring that the physicians are in their documentation being clear if it's either infarction or a hemorrhage, and really trying to essentially eliminate the use of this code where ever possible. We also look at transient ischemic attack, excluding G45.4, transient global anesia, transretinal artery occlusion, and central retinal artery occlusion, and thrombus of the intracranial venous systems. And you can see the codes that are there. This table just really reviews that certainly for 340 and 640, all of those applicable ICD-10 codes are included in both 740 retinal artery occlusion and central retinal artery occlusion are excluded. And also, which may be challenging to pick up, is if the patient's declared palliative before alpha FIM is performed, then it would exclude those cases, as the alpha FIM is a tool to triage patients to rehab. If the patient's palliative, there really is no need for that to be included. Again, looking at the cases to be included, again, as a review, it's all NACRS and DAG cases with the applicable condition, regardless of the diagnosis code assigned. Also, query strokes of the applicable condition should be included. Essentially, these patients undergo exactly the same workup and resource shares during their inpatient stay to either rule out if it's stroke or to confirm or rule out if it's stroke. We know, or it's transfers to and from another acute facility. Both facilities would complete the project on their abstract. If the patient has left AMA, died after admission, or declined treatment. And if there's multiple applicable conditions, certainly it would be completed for the initial current applicable condition. If the patient has an ischemic and hemorrhagic, the project would be done for the ischemic stroke, unless surgery is done for the hemorrhagic stroke, because that would be one of the exclusions in the clinical handbook. So moving on to talking about CHI 340, as we know, CT MRI within 24 hours, date, administration of acute stroke thrombolysis, date and time of acute stroke thrombolysis, antithrombotic medications at discharge, and date and time of stroke symptom onset are DAD and NACRS fields. Where the difference is with this is referral to stroke prevention clinic isn't only a NACRS field because the patient is discharged from the ED. And for those patients admitted, it's admission to stroke unit. So CT MRI, again, this is pretty basic. It's easy to capture. CT is the first line diagnostic test in acute stroke. It's readily available, easily tolerated for patients, reliable, and it really can differentiate between ischemic and hemorrhagic stroke. It really guides determination of our eligibility for thrombolysis. When we look at the CT scan, just a word of caution as we're looking is that the CT done very early in the first 3 to 6 hours may not pick up that very subtle early ischemia. In ischemic stroke, it can take some time for that ischemia to show up in the brain. And so what you may find when you're looking and coding the charts is this initial CT may be negative, but a CT scan or MRI done within 24 or 48 hours clearly identifies where the stroke is able to localize where the stroke is. And again, that is essentially just that initial CT done early doesn't pick up those subtle ischemia. One of the other things when we look at CT scan is it may not provides poor visualization of the brainstem and the cerebellum. And so you may not be able to pick up infarcts in those areas where an MRI might be required after the fact. You may wonder, well, then why don't we just do MRI on everybody? It's very challenging when MRI takes a lot longer. It's not as accessible. We can't look at getting it sort of our door to our CT within our 10 to 15 minutes that we're looking at. So really that's why we look at, patients have lots of exclusion, need screening. So CT really is that primary tool. Looking at the field completion, again, you know this as well or better than I do. Really, the options are prior. CT was done, CT MRI was done prior at an acute facility prior to transfer for that facility. Yes, it was done in 24 hours, or no, there's no documentation it was done. When we look at admission to stroke unit care, and this is a new addition for 2023, is really just looking at really defining and enhancing what that stroke unit care is defined as a stroke unit. And so it really is that specialized, geographically defined unit dedicated to the management of patients with stroke, staffed by that interprofessional stroke team, and really provides that coordinated management of patients, looking at early assessment, identification of stroke risk factors, early rehab, education to patients with stroke. And again, Steph has reviewed why it's so important and why we capture it. Ontario Health, Core Health, has really defined their stroke unit definition is a bit more refined than the best practices, is looking at that dedicated geographical unit with identified co-located beds that are occupied by patients 75% of the time, with a dedicated team with expertise, and really identifying at minimum what we're looking at with that team. So nursing, physiotherapy, occupational therapy, and speech language pathology. And so you can see when we look at, if we look at 640 date and admission to stroke unit, you can see why we capture it because we're really trying to capture that 75% of the time. So if it's a 4-bed unit, 3 out of the 4 beds must be occupied by stroke patients 75% of the time. For those that are outside of the unit and you're not sure if your areas have stroke units, there is info at Core Health Ontario and you can get a listing. For those of you in our region, again, as Steph has referenced, we do have acute stroke units, and you can see the units that are listed there. St. Catharines in Niagara Health have not had a stroke unit since July 2022. However, as part of their planning, we may see that change in 2023, and certainly Leanne Kent will share and communicate that with those sites. When we look at coding stroke unit care, it's really, did they spend any time during their acute admission on the stroke unit? We know our thrombolysis patients are sometimes patients based on their medical condition, if they're very hemodynamically unstable, or at the regional center may require admission to step down or telemetry units, may spend a portion of their time on those units and then get transferred. For those that are an integrated unit, it really is only their time spent on the acute portion of the unit, not their time spent on the rehabilitation part of the unit. So again, when we look at the rating, again, it's either yes, they spent time on the stroke unit, no, they didn't, or 8, it's not applicable. So either the facility doesn't have a designated unit, or new for 2023 that the diagnosis is subarachnoid hemorrhage. We know patients who are acute subarachnoid hemorrhage are often managed on a neurosurgical unit. They require close monitoring for complications, for vasospasm. And so certainly you may find, especially in some of our non-tertiary center sites that when patients are done their acute portion of their stay, but still requiring ongoing stroke management, may be managed on a stroke unit, but for the purposes of the special projects, subarachnoid hemorrhage is excluded for the project. When we look at referral to a stroke prevention clinic from ED, and so this is only for NACR's charts, we know that the risk of recurrent stroke after TIA or minor stroke is about 4% in the first 90 days, and that is front-loaded with about 3.8% of recurrent stroke in the first 2 days after symptom onset. We know the risk of having a recurrent stroke is really high after a TIA or minor stroke. And so really, stroke prevention clinics provide a comprehensive approach to preventing stroke. And the best practices would say, acute stroke or TIA should have that clinical evaluation to determine the risk of recurrent stroke, initiate appropriate and timely management and investigations. And so patients who with TIA or minor stroke who can be discharged home, our goal is that 100% of patients are discharged from the ED should refer to stroke prevention clinic. As Steph said, our organizations that provide acute stroke care, we have stroke prevention clinics at the Hamilton General, at Brantford General with a satellite in Norfolk, at Grand River Hospital, and at Greater Niagara General. They provide rapid access to stroke experts, timely access to appropriate diagnostic testing, and counseling to manage risk factors. Again, the completion is either a yes or no. Yes, there's documentation that a referral has been made prior to leaving it. It is recorded as yes if the referral is made, but the patient refuses. No, if there's no documentation in the chart of referral. So when we look at thrombolysis, administration of acute thrombolytic therapy, we know with an acute ischemic stroke, the only way to prevent that irreversible damage is to reopen the artery. As Steph said, acute stroke thrombolysis is one of those ways, and endovascular therapy is the other. And so the new for 2023, based on upcoming evidence that I'll talk about, is that all eligible patients with disabling stroke who can receive it, and we know there are inclusion and exclusion criteria for thrombolysis, should receive it with either alteplase or tenecteplase within 4.5 hours of symptom onset or last known well. Also, that they should receive it with a median of door to needle of 30 minutes or less. We know 2 million brain cells die each minute, blood supply is cut off, so we want to restore that blood supply as quickly as possible. So why did this change? Why is tenecteplase part of this? A Canadian multi-center trial of over 1,600 patients compared patients with acute ischemic stroke, compared alteplase to tenecteplase, and what they found is tenecteplase was equivalent, so equal, had the same functional outcomes and the same complication rates as TPA. So you may be saying, well, why would we want to switch if they're the same? What we know is TPA or alteplase requires a bolus over 1 minute, followed by an infusion over an hour. It requires an infusion pump, requires checking with 2 nurses. It's dosing, a very detailed dosing chart for it, where tenecteplase is a one-time bolus. And again, it's just a one-time bolus that's administered. There's much more simplified dosing, less likelihood for error. Again, so you will see across our region that shifting, and I'll talk about that when we move to the sites. So new, when you're looking and coding this into the special projects, thrombolysis, TPA, RTPA, recombinant TPA, actiphase, alteplase, and new tenecteplase or TNK. There is clarification because the coders that are coding both cardiac and stroke charts is that acute stroke thrombolysis is not administered in ambulances at this time, as it is with STEMI. based on their 12 lead. With ischemic stroke, there is no clinical diagnostic tool that paramedics can do that can differentiate between ischemic stroke or hemorrhagic stroke. And we really need that CT scan prior to administration. Certainly, some stroke ambulances, none in Ontario, but certainly some in the US and in Alberta, I think in Edmonton, have CT scanners in them. So can be given with support of sort of telemedicine to the paramedics. But in Ontario, we do not have any stroke ambulances at this time. So when we look at our thrombolysis sites, as Steph has reviewed those, and so certainly related to implementation of tenecteplase, the Hamilton General Hospital went live with tenecteplase in January. Grand River went at the end of February. Guelph General is looking to go live, I believe, in May. Greater Niagara General is hoping to go live in June, and Brantford and Joseph Brant are in their planning and will likely be later this year. What you will see when a site switches from tenecteplase to alteplase, it's 100% shift. You're not going to see both, you'll see one or the other. Where do you find it? Again, all of the sites have pre-printed orders. It is an intravenous medication, so it will be in the medication administration record. The ED nurses' notes. Nurses are very good at documenting when the start of it is with alteplase. It is when the bolus is given. It's not when the infusion starts. Also, the physician progress notes will indicate that alteplase was given, may or may not have the time. That's, I think, really you're looking at the medication administration record or the ED nurse's notes when you're looking at that. Again, this is either, when we look at completion of the special project field, it's either yes, prior. So for those that were transferred, the patient received thrombolysis at a prior facility prior to transfer. Yes, there's documentation received. No, they did not receive it, even though the site provides thrombolysis. As I said, there is a number of inclusion-exclusion criteria the physicians go through to make sure it's safe to give the patient. X if the facility does not give thrombolysis, and 8 if it's not applicable, if it's a hemorrhagic stroke. Again, the date and time of the administration, again, is very clear. It must be completed. If it's prior or yes, we're looking at the month, day, also the hour and time. Certainly sometimes you may not be able to have all of those, especially if the patient's transferred out. Really complete what you can. Certainly for EVT or repatriated cases, you can review the time was given in the previous NACRS chart as we're completing. When we look at prescription for antithrombotic at discharge, what we know is that early antithrombotic therapy after ischemic stroke in the first few weeks significantly reduces the risk of early recurrent stroke. The best practices would say all patients with an acute ischemic stroke or TIA should be started on an antiplatelet agent, ideally within 24 hours. We know patients who have received thrombolysis or endovascular therapy need to wait until that 24-hour CT scan is done to make sure there's no bleeding from that before it can be started. It goes on to say in the best practices that patients with TIA or atrial fib should receive an oral anticoagulant instead of antiplatelet therapy. And we know with the timing of this, it depends on if it's a TIA or minor stroke. If it's a TIA, ideally, the anticoagulant therapy should be started as soon as possible, ideally within 24 hours of onset. In the patient who has atrial fib and a stroke, the timing really is at the discretion of the physician, really looking at patient factors, and really what's determining that is the size of the infarct. If the patient's had a very large ischemic stroke, the patient may wait 5 to 10 days because of the concern that there may be bleeding. So sometimes you may find that the patient has a stroke, a large stroke with atrial fibrillation. The physician's indicating in his notes that they want to start anticoagulant therapy, but they want a follow-up CT scan in a week to make sure there's no bleeding or, before they start it. However, when we're looking at coding this, it is if there is a prescription, not the intention. The special projects really outline what are the inclusion and exclusion agents. So as we can see, the antiplatelet agents are ASA, clopidogrel or Plavix, combination ASA and extended release dipromiderol or Agrinox or Ticlid. When we look at the anticoagulants, it's apixaban, dabigatran, dalteparin, indoxapan, enoxaparin, heparin, rivaroxaban, and warfarin. So again, the special completion of this is either yes, no, not applicable, or unknown. And so yes, there's evidence of documentation. They were given a script. There's no documentation. It's not applicable. It's a hemorrhage or the patient dies. And 8, it's unknown. The documentation isn't clear. Finally, when we look at CHI 340, the key area here is stroke symptom onset, and there's been a lot of focus as we've looked at stroke symptom onset to really ensure we're improving the accuracy of collecting this. It is a crucial piece of information. It is thought that this is a really simple concept. It actually it's probably more challenging. It is more challenging in really determining the stroke symptom onset. As Steph said, the timing of when the stroke started really determines their eligibility for EVT and thrombolysis. Again, we know there's witness onset. So witness onset tends to be quite easy. I'm sitting here, I develop stroke symptoms. You all look at your watch and we know it is at 9:50. When the stroke symptom onset is not witnessed, we really look at last known well, and that can be when it can be a bit more challenging and sometimes require more investigation or conversation with the team. And so this is really, when was the patient last seen without stroke symptoms? And this is sometimes where you may find conflicting information in the chart. So for example, we see this with wake-up strokes or, patients is found with stroke symptoms. So I'll give you an example is, sometimes you may find that the paramedics will say, in their note, patient woke up with symptoms. Symptoms started at 8 o'clock when the patient got out of bed. So 8 o'clock is identified as the stroke symptom onset in the paramedic record. However, the paramedic, in their time to quickly assess and transport that patient to the closest stroke center, we don't want them to spend, hours and hours or long time trying to get that information. We want them to quickly assess them, stabilize, and get them to the hospital. However, the ED physician, the telestroke neurologist, or the stroke neurologist at the stroke center, in communicating with the wife, asking the question to say, well, did you speak with them when the patient got up? Did they have any symptoms? Were they their normal self? It may become clearer at that time that the wife says, oh, well, I didn't speak to them. He just got up and he had those symptoms. In that situation, actually, the last known well would be when the patient went to bed, because we don't know if they woke up with symptoms, if it happened 2 minutes after, because we have no way to identify what the patient was like. And so that's sometimes why you may see conflicting information. If you do see conflicting physician information in the chart, certainly the 340 abstract does say the ambulance onset time would be given priority. But again, sometimes you'll look at it and the physician note is very clear that says, spoke with family, also recognizing when the family members or the bystander that finds the person may be quite anxious, and so may be a bit confused and may not hear what's being said to them. And when they're sort of clarifying and the questions are clarified, it becomes a bit clearer. Again, you all are aware of this quick reference guide that talks about, if it's, there's no time indicated, is it early morning? What does that mean? Early evening, and utilize that reference. I do see that Our physicians and our ED colleagues really try to look at, and giving it time, but certainly if it's not clear, you do have that estimated reference. Again, completing the special projects, you're really looking at the year, month, day, hour, and minute. Certainly, if it is unknown, record what you can. Really, if possible, try to minimize the unknown when you're capturing the field. But if you know most of it, so if it's 2 days ago but no time, indicate the date and unknown for the day and year. If there's sort of nothing in the physician charts that can help you guide that. So going on to 640. Again, looking at for NACRS, dysphagia screening and telestroke consultation is in the NACRS. In the DAD, it's dysphagia screening, telestroke, stroke unit admission, discharge. And we know ED triage date and time is something that's already captured in the NACRS fields. So is something that, because it's captured in NACRS already separately, it is not required. And for DAD, if the patient had a NACRS field, it's not required. So when we look at dysphagia screening, we know that dysphagia in stroke patients is as high as 65%. Really can lead to aspiration pneumonia, malnutrition, and death. So really important that we're screening patients at risk for dysphagia. And the best practices would indicate all patients should be screened for swallowing impairments, including before oral intake, including medications, food, fluids, and meds by individuals who are trained using a valid tool. It is done at the bedside by nurses. You may see in some organizations that don't have SLP, a registered dietitian is documenting a screen. You may only see an SLP assessment in some situations, or some physicians may do a 3-ounce water test. What qualifies as a screen? There are identified tools that organizations will use. Most will use one type of screen, so find out what it is, find out where it is. If you switched in your documentation system, find out where it's documented. You may see the STAND, the standardized swallowing tool for adult neurological dysphagia, the TORBEST, the 3-ounce water test, the dysphagia swallow screen. You may also see an SLP dysphagia assessment. Or the SLP may do a video fluoroscopy or a flexible endoscopic evaluation of swallowing or a FEES. It's usually and should be done ideally within the first 24 hours, can be done in the emergency department. You may see a dysphagia screen and an SLP assessment. Certainly if the dysphagia screen is abnormal, SLP would follow up to do a more detailed assessment. When we look at completion of the project field, it's yes, there's been a screen, no, there's no documentation, or 8, it's not applicable. Here, the patient is unconscious or on a ventilator, otherwise incapacitated, and dysphagia screening could not be performed. When we looked at telestroke consultation, and Steph has really reviewed what it is, all consults facilitated by Telestroke Ontario must be captured in this field. You do not need to see the Telestroke physician's consult note to code this special project field. If the ED physician's record, their notes, the consultant notes indicate Telestroke consult, then that would qualify as a Telestroke consultation. It should be collected whether or not the patient received hyperacute treatment or not. And new for 2022, in April, all sites must complete, all Telestroke sites must complete the Telestroke consultation project field, including when the patient is transferred to another ED with the applicable condition. So in this case, both the sending and receiving site would complete it. Again, documentation is either yes, no, or not applicable. 8, And so if the site is not one of those telestroke sites, you would be using 8 as we go. And as Steph said, there is a big focus on improving the quality of capture of this special project field. The stroke sites and your stroke leads do a reconciliation monthly. And so really reach out if you're having trouble finding it in the chart. When we look at date and time of stroke unit admission, as I said, we're aiming to have the majority of their stay on a stroke unit. And so that's why we really capture this field. Again, it must be completed if admission to stroke unit is a yes. As we go. So we're really looking at the month and day that the patient was admitted to the stroke unit and month and day the patient was discharged from the stroke unit. Finally, as we talked about with ED triage time, it is part of the ED admission, the triage assessment. It's important, and again, it is a field captured in NACRS, but that we use the triage time is considered all door time, I'll use in air quotes, for our door to needle time and our door to puncture. And as we indicated, it's optional if the entry code is E because it's already captured in NACRS. Again, capturing this is year, month, day, hour, and minutes. Again, you can use the unknown. However, I find the triage time is usually well documented and often a stamp in many ways. So really trying to indicate what you're capturing as we go. So moving on to CHI Special Project 740. Again, the Alpha FIM is a recommended tool provincially and nationally for all stroke admissions. It is a tool that provides a consistent measurement of the patient's stroke functional status and impairment. It really supports discharge planning and determines rehab needs. It is done by credentialed, typically occupational and physiotherapists on, or as close to day 3. And so certainly you are recording the assessment done at your site, not one that was done at the transferring site. And if you receive a patient back, it is day 3 of admission back to that site. Again, there are some exclusions for 740, which I referenced, the transient retinal artery occlusion and the central retinal artery occlusion. And if patients are declared palliative, before the assessment is done, it's not required because Alpha FIM really predicts the rehab needs. When we're looking at completion, it's either a yes or no. We're looking at the date of it being complete. We're also looking at, there are 2 elements that you'll see, the raw motor rating, which is 2 characters, a score of 13 to 81 or 99 if it's not known. And their raw cognitive score, which is also 2 characters, 7 to 35 or 999. So moving away from the special projects, one of the questions that came up in last year's is, can we talk about coding the special project with type 2 or our post-admit stroke diagnosis? It is required for type 2 or post-admit diagnosis strokes. However, as you're aware, likely more aware than I am, is the pathway for type 2 diagnosis or post-admit strokes is not as standardized as for patients whose primary diagnosis is stroke who are pulled to the stroke unit. Not all stroke patients may be pulled to the acute stroke unit. Their primary diagnosis may be their primary need and where they need those care needs prioritized, and their stroke care needs can be managed there. Some are. However, the challenge is, as a result, you may not be able to find all of the elements for the special project. And so really code what you can find. If you're finding you have a consistent challenge with a particular area of type 2 diagnosis where you're consistently not finding various elements, reach out to your stroke lead. They, as staff has flagged, really focusing on how do we capture and improve our documentation. And so we're able to look at quality improvement. Moving on to sort of stroke subtypes, complications, sequelae of stroke, and risk factors at the end of the presentation. So again, you'll know this as you're coding stroke subtypes. To really remember this, different strokes need different codes. Really remember the table and code from the immediate chart. Assess the spinal diagnosis for specificity. Review the documentation summary, impressions from relevant consultants. If you're seeing neurologists doing a consult on these cases, internal medicine, relevant diagnostic imaging reports. Again, remembering it's not just the initial imaging, which may be negative. It's any follow-up imaging, if there's any CT angiograms. And so really, is there an MRI that we may be able to pick it up as we're going? What you will also see when you're getting more of the specificity related to this is that the physicians in their notes, again, recognizing there are sort of residents, interns, med students, is they may use thrombus interchangeably for both embolic thrombus and thrombotic thrombus. Again, they think of it, it's a clot that's traveled, in the artery versus, an embolic stroke or a cardioembolic. You will often see they may use intracranial atherosclerosis or ICAD. They may use cardioembolic or artery-to-artery thrombosis for embolism. Again, you'll often see our physicians tend to think about when they're looking at this is localizing to the area of the brain, and so may not be as specific when we're looking at the cerebral arteries in all cases. Again, we know a lot of our hyperacute stroke, our hyperacute protocol includes a CT angiogram, but some outside of the window may not have that done. So they may be able to identify the area of the brain, but not pinpoint exactly where that thrombus. Also, again, when we're looking at etiology of stroke and we're looking at an ischemic stroke length of stay of about 4 to 5 days, they may be thinking that it is a cardioembolic stroke, but the initial either Holter, ECGs may not have picked up the atrial fibrillation, which may paroxysmal, may come and go, and though they're highly suspicious of that, but they don't have the cardiac monitoring to support that, and the patient as an outpatient may be looking at more 14 or 28-day monitoring. Also, it can be challenging, especially if the patient has multiple risk factors. So they have carotid stenosis, atrial fib, ICAD, intracranial atherosclerosis, that the patient, based on the location, the pattern, it's likely related to this. But if the patient has multiple risk factors, it can be challenging to say it is this particular risk factor that's caused it. When we look at complications post-stroke, Accreditation Canada Stroke Distinction has identified some common, again, we know pneumonia, and you'll see the stroke codes there. Pneumonia, again, we're looking at anywhere for the risk of aspiration between 4 and 10%. Urinary tract infections, again, you can see the codes. The incidence of symptomatic urinary tract infections are anywhere between 5 to 27%. Venous thromboembolism, again, maybe as high as 10%, so it's important to track. Pulmonary embolism is low, but is a significant complication post-stroke and increases the risk of death. So a really important complication to track. Pressure ulcers, again, about 8% and low, but again, something we want to track because, again, we look at capturing and putting in prevention strategies. Secondary cerebral hemorrhage, we know that this can occur naturally after the primary infarct. About 6% of patients with ischemic stroke may develop secondary hemorrhage in the infarcted brain as the clot breaks down in the artery and blood returns to the area of the brain. When the arteries distal to where the clot has been, they become brittle. And so then as the clot breaks down, we have blood flow come in. I often describe it as a tree in an ice storm. It's like the blood comes in, hits the artery, and may have little petechial bleeding into the infarcted bed. The risk of intercerebral or secondary hemorrhage after thrombolysis is about 3%, 3 to 4%, and after endovascular therapy is again about 3%. Cerebral edema occurs in about 10 to 20% of ischemic strokes, usually in about day 3 to 5. Often with patients who have a large artery occlusion in younger patients who don't have as much space in their brain. And when I say younger, those typically under the 50 that we're looking. And especially if the patients has had endovascular therapy and they weren't able to open the artery, they may be at risk. And why does that happen? And when we look at edema, it's because of the disruption of the blood-brain barrier, which causes swelling of the cells. And again, you may see patients, especially if they're transferred out to the neurosurgical center, maybe started on mannitol or a 3% saline to help draw that excessive fluid off prior to doing it. I do flag that with subarachnoid hemorrhage, there are a bit of unique patterns we can see in these patients post-subarachnoid hemorrhage. Certainly, they may have the same complications that are listed on the left side of the screen, but again, they may have cerebral edema. They may have hydrocephalus due to blockage of the subarachnoid, the blood, blocking the CSF, the arachnoid villi, which causes hydrocephalus. They may have vasospasm, which the blood causes the artery to constrict and spasm that may cause an ischemic stroke after subarachnoid hemorrhage. And they may have rebleeding if the aneurysm is unsecured within the first 4 to 48 hours, and the risk is high in the first 2 weeks. So when we look at stroke complications, again, we know that any secondary ischemia after hemorrhage is included, secondary ischemia after hemorrhagic stroke is included in the hemorrhage code. Any extension of the single hemorrhage is included at the site of the origin. If there are separate or distinct separate hemorrhages, they would be concurrent. This is pretty unusual that we look at. Typically, if you have an extension, that often it is in the same site as the origin. Primary interventricular hemorrhage confined to the ventricular system is uncommon, only about 3% of the time, and I-61.5 should only be assigned for primary interventricular hemorrhage. Often what you see is you have an intercerebral hemorrhage that extends into the interventricular system. So that would be considered an extension. Primary interventricular hemorrhages may be caused by aneurysm, AVMs, or tumors in the choroid plexus. If we look at any naturally occurring secondary hemorrhage or bleeding after thrombolysis is included in the infarction code. If you're looking at, sometimes you'll see recurrence or recurrence of stroke symptoms. So the patient looks like they're presenting with stroke. What this is referred to is reappearance of previously resolved symptoms of a remote ischemic stroke. And it's not a stroke. It can be triggered either by physiological factors. It can be triggered by metabolic abnormalities, often triggered by an infection. Sometimes we'll see patients who will come in with urosepsis or pneumonia, who their previous stroke symptoms have been exacerbated, and they may come in as a new stroke. It accounts for about 30% of stroke presentations that you may see, and often they've had a previous history. Those are not actually considered strokes as we're going. Moving just on in the last few minutes of the presentation, I know I'm sort of at the end, really wanted to just sort of summarize sort of the sequelae and the common complication, and it's really sequelae versus complications of cerebrovascular disease that we see, and again, the deficits. Again, we know the coding is based on their subtype. Maybe those cognitive deficits, and you can see the ICD codes that are listed under what we would consider cognitive deficits, looking at their speech language deficits, again, and what those would quantify, the one-sided weakness of their upper limb, if they have one-sided weakness of their lower limb, do they have, it's not identified, if they have hemiplegia of the dominant side, what does that look like? Other paralytic syndromes, so what does that look like? And then really looking at some of those other sequelae of stroke, so apraxia, dysphagia, facial weakness, ataxia, and others. And again, so you have this as the reference. Finally, looking at stroke risk factors, and again, it really is a lot of stuff flagged with some of our some of the monitoring we do. It really looks at, you know, what are their risk factors? And so really, if you're able to flag and code some of those risk factors, if you're looking at atrial fib, as you said, a lot of we look at is, you know, antithrombotic therapy for patients with atrial fib, their hypertension, their diabetes, and their hyperlipidemia. It really just enhances the complexity and the weighting and coding of the case. And I know we've really focused on our documentation with our physicians to really be clear in their documentation what that looks like. So I'll just stop and I'll just, again, we are a few minutes over before we go to break. So I will take a couple of questions if there are any questions from the audience. If not, we can look at those when we go into our case studies. I don't know if there's any questions in the chat. You can either also either put them in the chat, put them in the Q&A, or you can raise your hand. Debbie, anything I missed that you wanted to highlight for the group?
No, just basically reviewing your documentation, and if you're not sure, querying the physician is usually what CIHI directs us to do. So yeah, and stay engaged with your stroke team.
Okay, I'm not seeing any questions in the chat. And so we will take a short break. We'll come back at 10:25. And then what we'll do is we'll go into some case discussions for 3:40, 6:40, and then move on with the rest of our morning. So we'll see you back at 10:25. To resume the recording. Now what we're going to do in our presentation is really move to some case discussions. And we're really hoping for interaction with our participants. And we will have some polls that we will be launching. And so in this situation and with this part of the presentation and our next case discussions, really, the options that you can look at here are is you can put a question in the question and answer. You can raise your hand. You can put a comment in the chat. And certainly we will allow, and if you raise your hand, you'll come off mute and you can ask your question. So we're going to start then moving forward with our first case. And so in this case, we're focusing on stroke symptom onset. And so here you can see we have the paramedic record where The date of occurrence and time of occurrence indicated in the record is 2021-09-28 at 7 o'clock. You can see in the note that the paramedics indicated the patient and husband were not good historians. The patient went to sleep at 2300 with no symptoms, woke at 7 and was ambulating independent. Husband noted the patient was acting weird and unable to use hand-eye coordination when she was refilling her water bottle. She fell at 7:20, developed left-sided facial weakness droop at 7:30. When the paramedics arrived, the patient was a LAMS, I think it must mean 5 because 5 is the highest, a left-sided facial droop, slurred speech, left arm droop, no left-sided grip, and patient unable to ambulate. The patient was complaining of a headache of 2 out of 10. The telestroke report indicated that the patient was awake and at her baseline at 7, while having her coffee at 7:40. Her husband noted left facial droop, left arm and leg weakness. She had deviated gaze to the right, her flaccid left arm and leg. No improvement since the onset. Her initial BP was low, which resolved, and she was independent prior. So think about what information you have and what was the stroke symptom onset. And what I'm going to do is I'm going to launch the first poll. What I'd like you to do is, based on that, you should have the option to select what you think the stroke symptom onset is. Was it 2021-09, 27-2300? Was it 2021-09-2807, 2021-09-280720, 2021-09-280730, 2021-09-280740? And once we give people a chance to indicate their responses, we'll wait till we have we'll talk about what are some of the factors we considered in selecting that. We'll just wait a couple more minutes. Okay, I think most the sort of collecting will end the poll. And so we'll share the results. And so what we can see is about 27% say that it was 2300, so the night before. 45% say at 07, 9% would say it at 720, 11% at 730, and 9% at 740. So I'm going to stop sharing. Again, and so when we look at this, when we were thinking that what we were thinking is really it was sort of that 720 Again, because we had conflicting times that we look at going with the paramedic report, where we look at that she was at 700, she was ambulating independently, and then she had symptoms. So what factors did people consider when we were going with this? And is there any questions or discussions? Certainly put it in the chat or in the Q&A. Or Debbie, any comments with this?
No, not at this time.
Okay, I'll move along. So now we're going to go on to thrombolysis. And so here you can see a case where the triage was at on 280921 at 0909. Had their CTA, so the first slice was at 916, which showed a right MCA infarct. You can see the documentation of the TPA. They got 8.4 milligrams in an IV bolus. And then their TPA infusion of 75.8 over an hour at 9:55. And the TPA bolus. So what was the time of thrombolysis? And so I'm going to launch our second poll. Oh, sorry. I've shared the results. So sorry, I have to go back to the next poll. I'm closing that, sorry. So look at the times, and is it at 9:55? Is it at 9:54? Is it at 9:50? Or we know it was on 0928, but we're not sure. Give people a chance to respond. We'll just wait for just a couple more minutes to give people time to respond, and then I see that slow down. Okay, I'm going to end the poll. I'm going to share the results. And so again, we can see at 9:55, 9:54 at 10%, 9:50 at 50%, and 9:99 at 13%. So what kind of factors did people consider when they were determining the time of thrombolysis? Certainly it's challenging to see. So again, we could see that it could look like a 9:50. We know what we can read was the 9:55. What we do know when we look at thrombolysis is that the bolus is given, oh, there's, sorry, good comment in the chat. So great, thanks so much. It is the time of the bolus, is things that people consider. And so when we look at this, it is the time of bolus, not the time of the infusion. And so in this situation, 9:55 was the time of the bolus. Or it was the time of the infusion that we see. We know that the bolus is given 1 minute prior to when the infusion is given. So in this situation, and I did confirm with the site that sent it to me, was at 9:54. So we know the infusion started at 9:55. The way our sites, certainly in our region, will give it is often through their intravenous pump. So the pump automatically gives the bolus over 1 minute and then reverts to the infusion. But certainly in this situation, you can do exactly as I did when I reached out to my site as we're going. And that we would go along. And so certainly when we're looking at it, that we would see that I reached out to my stroke lead at the site and said, hey, Amy, is it 9:54? What is the time? If it's not clear in the documentation, looking for other spots, is there a spot in the other areas where it might be? Thanks. There's a comment in the chat about sort of strokes symptom onset. Again, one of the things that the group had indicated, or the comment, is that there was lack of coordination noted at 7. Again, so you're right. Again, when you're looking at this, you know, they woke at 7, was ambulating. The patient was noticing they were acting weird. And so again, that's where, again, you could look at with some of this, you know, and again, it's hard to tell from the telestroke report because it's not as perhaps as specific. But again, the telestroke neurologist has then quantified, you know, the patient's awake was at her baseline at 7, and then really clarified with the husband, when did those symptoms start? But again, looking at where you're going, and that's a good example where it's not always as easy as you're pinpointing. I think there's a question or comment, Steph, in the chat, in the Q&A.
Yeah, sorry, I just wanted to highlight it just in case you hadn't seen it, Rhonda. There's an attendee just asking if we could let them know the answer to the poll question number 1.
Okay, so the answer to the, again, the answer to poll question number 1 that Debbie and I had looked at was 7:20 when the patient sort of fell with symptoms. Okay. So, sorry, I'm moving back and forth. So the next one is looking at an example of tenecteplase. So thrombolysis with tenecteplase. And so here you can see, and this was actually sent to me, myself, by one of our coders. Again, looking to see where it might be. And so what you can see is, again, is pulling from what you can see is the ordering provider, the notes, also looking at the medication administration record. So you can see the status. It was ordered at 10:31. It was started at 10:35. It was given at 10:39. And then you can see in the MAR that it was administered at 10:39, that it was 20 milligrams or 4 mLs. So what we will look at is then the date and time of the tenecteplase bolus in the poll, and I'll launch that poll. So was it 01/31/10:30? 01/31/10:39, 31/01/10:39, or I wouldn't code it as it's not one of the thrombolytic agents referenced in the chart, in the special project. Yep. Question, can I move back one slide? Absolutely. Oh, sorry, guys. I realize if I open that, you're seeing that. Okay. I'll wait until we're about 60%. I'll wait till about 2 minutes when we see it sort of slowing down. Okay, I think responses are slowing down, so I'm going to end the poll. I'm going to share the results. So we can see about 30% felt it was at 10:35. 39% felt it was at 10:39. 26% felt it was at 31:01, 10:39. 5% wouldn't code it as it's not one of the thrombolytic agents that were part of it as we're going. So I'm going to stop sharing. And I'll go back. So in this situation, and this is a great example of, it came from Hamilton Health Sciences. We went live in January of 2023. It's a different mechanism in our electronic medical record. And so the way the order looks at is the 1035 is when it was pulled from the OmniCell. So that's when they took it out of the OmniCell. But when it was actually given was at 1039. So this is when the actual nurse had the bolus given intravenously. And you can see in this situation, 1039 is when it was given. So in this situation, the correct answer is B, 01/31/1039 as we're going. One of the things that you will find with our sites that we're going is they will inform your health records coders that they have made that switch and that we will be utilizing Tenectaplace for that and going to it again and having that conversation about what you're looking as we're going along. I do notice in the chat regarding case 1, there's some comments about, you know, she was not at baseline when she woke. And it's important to code the time it was administered, not the time it was ordered, because as we know in our electronic systems or even in our paper systems, it may be ordered at a time, but it is actually the time that was given as we're going along. That is recorded in the special project. So I'm going to go on to our next case. This is telestroke consultation. And so here we can see the triage note. Again, similar with the case we had before, was 280921 at 9:09, had our CT at 9:16, had the bolus given at 9:54. And you can see here the telestroke consultation note from the case that we presented earlier. So would you code telestroke consultation field 147 with this case? Yes, no, or 8, not applicable. I'm going to launch the poll for this and give people time to respond. Okay, it looks like responses to the poll is slowing down. So I'm going to end the poll and share the results. So again, the majority of people would say, yes, I would code this. So 91%, 6% were no, and 2% were not applicable. So again, in this situation, we would code it. This site is an Ontario telestroke site. They've utilized telestroke, so it would be considered. Those that would indicate no or not applicable, I'm not sure what factors were people considering, and you can put it in the chat if you'd like, or in the Q&A in your responses for that, and we can move forward if there's questions with that. And it may be related to the fact that your site is not a telestroke site. So the question is, does the documentation specifically need to state telestroke, or can it be assumed if the physician states only stroke consult? So that's a really great question. Typically, the sites that utilize telestroke will indicate telestroke consult, that they've consulted telestroke through Criticall on the ED physician's note. Some sites that have their internal stroke team would indicate stroke consult, but that wouldn't quantify as a telestroke. It really is, when we look at the telestroke, it is linking through the Criticall, through the Ontario telemedicine program to the telestroke neurologist provincially. And so typically, and I defer to some of my sites that are telestroke, so either Amy or Elke or Candace or Tammy, others in the chat, typically the physician will say telestroke consult, that they would indicate that in there. But I'll pause to see if my colleagues can comment on really how their physicians would really be documenting that.
Actually, Rhonda, at Niagara Health, our physicians are very clear when it comes to telestroke consults.
Perfect. Other sites? You may see, and again, I'll utilize Hamilton Health Sciences, or again, even Grand River. Certainly, they may say stroke consult, but that's consulting our internal stroke team. And again, even at Niagara Health, during the day, they may do a stroke consult. You know, and Grand River during the day, they're consulting their stroke team, but they would write telestroke and or stroke through critical as they're going, and it would be documented in the physician's consult note, and they may say OTN stroke neuro or other versions. But again, if you're seeing OTN, which is the Ontario Telestroke Network, again, Amy has flagged, and I think, again, I've looked also at enough ED charts as I'm reviewing cases, is it can be challenging sometimes to decipher what it is. As part of improving the capturing of telestroke, we've really focused with the physicians to try and be clear to say, you know, Ontario telestroke, you know, telestroke, OTN stroke, because you're right, as Amy had identified earlier, our referring EDs may refer to other specialty services from the ED for stroke cases, especially hemorrhages. They may refer to neurology or neurosurgery. And so those would not be considered telestroke. So it is important to look at that. And so what I'd flag when you're looking at it, if you're having struggles finding it, is link with your stroke sites. Each telestroke site and our stroke teams, our stroke sites, do a monthly reconciliation of telestroke consults to back through to critical. And so there's a good way to do a cross-reference with that as you're going along. So I'll move along. Our next case, and so this case was a male patient brought to by ambulance on December the 28th of 2021. Patient did have a positive COVID test on December 25th, 2021. You can see the paramedic record. So again, the date of the occurrence is 2021-12-28 at 13:30. They had the history with the wife and patient on scene. The wife stated the patient was last seen completely normal at 13:30 hours. Patient began to complain of headache at 1400. Stated the headache was 5 out of 10, took 2 Tylenols at that time, went down for a nap at 14:30 hours. At 15:30 hours, patient woke from his nap and was discoordinated, falling from his chair, striking his head. Didn't have any trauma from the fall. The wife states the patient was incontinent of urine and had to be helped to the bathroom because his gait was weak. Had facial droop at 1600. When the paramedics arrived, had left-sided facial droop, left arm weakness, slurred speech, and right eye deviation. Had a headache of 2 out of 10. And the arm weakness resolved during the paramedic transfer, but the patient remained with slurred speech, eye deviation that remained at transfer of care. Here you can see the telestroke consult note, and you don't see all of it, but you see a snippet. So the patient was evaluated for treatment of possible acute stroke. Onset of symptoms was 2 days ago. The patient was awakened with symptoms. He had developed a right-sided headache 2 days ago, and then today at 2:30 he slept, and when he woke up at 3 p.m., head, right hand, and face weakness. He has right side, his current symptoms include right-sided headache, left face weakness, and hand weakness affecting the left side. The symptoms are currently improving. The physician indicates was not a candidate for IVTPA because they had a low NIH, so low neurological deficits, an established stroke on CT imaging. And so remember I said often a CT done early in those first 3 to 6 hours would be negative. If an established infarct, so very clearly showing areas of ischemia in the brain, often that indicates to the physician and the radiologist that the stroke has happened a number of days or hours before. As we said, it can take time to come up. And the patient had a headache for 2 days ago. And then it goes through and talks about some of the care and management that this patient would go. So what we're going to again look at here, and I'll share the poll, is what is the time of stroke onset? So again, we'll give a couple of minutes for people to answer the poll.
Rhonda, are you able to go back to the ambulance slide?
Oh, sorry. Yeah, thank you. Sorry, I appreciate those. I'll move this down. I'll try and move this up so people can see. Hopefully people can see the ambulance slide. I'll wait till just 2. We're getting good participation in this one, so we'll just wait a couple minutes till it slows down. Okay, I'm going to end the poll and share the results. So here we can see at 1:30 on December 28th is 30%, 1400 on December 28th at 38, 5% at 1600. 11% is December the 26th at 08, and 17% is that it's 21/12/06/999. So I'm going to stop sharing. I'll go back. I'll go forward, and I know there's some comments in the chat. And so this one I think is really, again, looking at sort of our comments, and I'll just quickly look in the chat, then gone back a slide, and I'll look at the questions.
Yeah, and I was just going to help out with the question.
Yeah.
The question is the one option supposed to say 26th at 999, or was it meant to say 06 at 9999?
So great point. I realized that that was a typo. It should have said 26 at 9999. So thank you for catching it. To see to see if you were still awake mid presentation. Absolutely not. It was a complete typo on my part as we're going. And so this one is really again more so for a discussion again. And some are saying it's not as clear as we think it might be as we're going. And so this one is typically, we wouldn't think of a headache as we're going along with this. But I think when we look at, this is where sometimes the neurologist's note may have an indication that, especially because they had the established infarct, that the neurologist attributed that the headache was likely the start of it. Maybe patient had minor symptoms. However, again, I'm not saying it wouldn't be wrong. I can certainly see why the coders would say, you know, the physician, the paramedic note very clearly says, last seen well at 1330. They complained it had at 1400. And so again, on that same note is that, you know, if the neurologist is saying the headache, they were well before that, they've had new symptoms. Was it fluctuating symptoms? It's hard to tell when it's looking at it and going forward. And again, in that situation, the patient had this headache 2 days ago, and then again at 2:30 as they're going, or 2 o'clock again. And so again, this is where I think was really meant to illustrate that it's not as clear as we're looking at, and we sometimes think about where it might be. And if you really have questions, to really reach out to your coders or reach out to your stroke team. And Debbie, any sort of comments and suggestions related to this?
Only that this is, you know, one of the major pain points, as we all see, is the fact that there's always conflicting documentation. There's not too many times where, you know, you'll have consistent on the ambulance and all the consults. So all you can do is just go case by case and, you know, do the best you can and, you know, follow the CIHI specs for the project capture. And that's all you can do. And again, reach out to the stroke team if that's a possibility as well. So.
Perfect. Okay, I'm going to move on to our last case. Would there be an instance?
Can I just highlight, there's a question in the chat. Would this be an instance where you go via the telestroke MD versus EMS?
Yes, yeah, I would say in that situation, because of the further information where the physician is saying there is that very established infarct. If the CT was negative, again, I think the neurologist would very clearly say, you know, that it would be that, you know, 1330, or when they were last seen well, or when they developed the headache, because again, it was witnessed. So that 1400, because at 1330, they were last known well. 1400 is when they developed that headache. And so if that CT, I think for me, when I think about what was that determination, is that this stroke was a very established infarct. And so it's unlikely that the first recurrence of symptoms on December 28th were the first symptoms related to it. It was likely more a progression of it. So great question, Steph. Thanks for coming on. I'm just going to move to our last case where, again, because I know there were a lot of questions regarding this, and I'm going to turn it over to Debbie. Oh, except I went too far to present this case, and then we'll launch the poll for this.
Okay, thank you, Rhonda. So we have a 78-year-old male who presented to the thrombolysis center at 31 minutes after midnight. He had a witness collapse at home at 21:45. He was found with profound right-sided weakness, expressive aphasia, and on arrival to the stroke center, his NIHSS score was 18. On arrival, CT showed decreased attenuation in the right parietal lobe, keeping with an old infarct, and there were large plaques calcified seen within the left vertebral artery. Patient received IV TPA in the ED, and at 15:45, there were no obvious complications from the TPA, but not a clinical improvement.
So next slide, there we go.
Atrial fib was noticed on the ECG in the ICU. 24-hour follow-up CT showed an old infarct again within the right parietal and occipital lobe. There was a subtle area of decreased attenuation noticed in the left frontal lobe, and it was likely a left anterior cerebral artery territory infarct, MCA. So day 2 at 21:40, patient developed decreased level of consciousness, and an urgent CT showed there was a hemorrhagic transformation of the cortical infarct. And there was a discussion with family post-CT regarding the patient's condition. Patient was made DNR, and palliative approach focus of care was taken from then on, and patient passed away in hospital on day 3. So go ahead.
Go ahead, Debbie. No.
How would you code the hemorrhagic transformation from the infarct? And what factors do you consider?
Okay, I'm going to launch the poll. I'll wait a couple of minutes, give people time to respond. Okay, I'll wait. I'll end the poll when we're at 2 minutes. All right, I'm going to end the poll. I'm going to share my results. And so again, here we again see a mix. So 27%. I say it would be an I61.9 in a cerebral hemorrhage type 2. 32% would be an I63 ischemic stroke. 29% would be I61.1 intracerebral hemorrhage type 2, and 13% don't know. So I'm going to stop sharing, go back, get our slides. So again, Debbie, we had selected B. Do you want to talk about sort of why we would consider that as we're looking at the response with this?
Absolutely. So there are standards for acute strokes. It's indicated that a hemorrhagic transformation would not be coded, and you would code to the original ischemic stroke. I know a lot of times in our charts, we'll see post-TNK bleed, and it's documented that way very often. And so I have sent off cases to CIHI with all the documentation, and their response for that was, you do have to be very careful of how it's stated, But basically, when they state a post-TNK bleed, they feel that's more of a timeline statement rather than a cause and effect. So you really have to be careful with the documentation. And if you think that it's a complication, you just check back with your physician for confirmation. You can send in a query to CIHI with that particular documentation, and you'll get the guidance. But we have to be very careful of which complications we report, and report them if it truly is a complication.
Thanks, Debbie. We have one more case, and I think we will do it just because I know this was an area or one more question, a poll to do, and we'll go through this before we move on to our next cases. And this was looking at what would the MRDX be for this case, and I'll launch this poll. So would it be I-63.9, unspecified, I-63.3, ischemic stroke, stenosis, occlusion or stenosis cerebral artery, I-63.4, ischemic stroke, embolism, cerebral artery, or I-63.5, occlusion, stenosis, NEC, NOC, cerebral artery. And again, we'll give a couple of minutes for people to respond.
Ron, I think there's a request in the chat. Just
Okay.
go back to the slide while the just I think to help with the question.
Sure. Sorry, I'm not. Oh, in the chat. Go. Oh, first slide. Is that okay? Yeah, and go back to. Oh, sorry. Go back too far. All right, I have to get to my polls again. I'm not sure where my poll is. Hopefully I have not. Okay, sorry. All right, we'll give it just one more minute. Or one more, I just didn't, as people are coming, we'll end the poll in a few seconds, sorry. Okay, and end the poll and share the results. So again, we see a bit of a mix, I-63.9, 26%, I-63.3, 30%, I-63.4, 8%, and I-63.5, 36%. So I'm going to stop sharing and we'll go back. And again, oh, no, wrong. Hopefully if we're on the right slide. And so, Debbie, if you want to talk about sort of what we'd look at with this case.
Yes, definitely. So we'll note that the first CT angio showed calcified plaques in the vertebral artery, which is a precerebral. The second CT showed likely an anterior cerebral artery infarct, but we have physician documentation that confirms that MCA within the chart, and so that would be the critical occlusion, and we would code I-63.5 because it's not stated whether it was a thrombus or an embolus.
Okay, great. So that ends, and certainly we will share these slides, and you have Debbie and my contact information, but we're going to now move on to transferring patients throughout the region. And what we will do is we'll have more case studies as we go related to those. Sorry. So again, when we look at transferring patients across the region and really what does that impact have for the special projects is recognizing it can be very challenging when we're moving patients, and what does that mean for completion of the special projects. And so when we look at it, we know transfer from an acute facility to another acute facility, both facilities would complete the project in their abstract. If we look at if we're transferring from ED to ED, the final facility would complete that. And again, I will flag there's a couple of caveats to that. And if the patient's admitted from ED to their own facility, obviously it would be in the DAD abstract. If they're admitted to a different acute care facility, the project would be captured on the ED level 3 abstract of the sending facility and the DAD abstract of the receiving facility. And so just to flag, when we look at two steps point when we were talking about telestroke, there is, as we're trying to improve the documentation of our telestroke consult, we saw that those patients that were transferred out was an area where it was a gap with completion of the special projects. And so in 2022, Ontario telestroke sites must complete the telestroke consult field, including when the patient is transferred to another ED, if they have the applicable condition. So both sending and receiving sites would complete the 640 field. So when we look at the situations that may be transferred across the region, the first one is looking at, as Steph said, transferring patients from non-thrombolysis centers, either from the ED or inpatients, to the acute thrombolysis centers. And so Steph talked a little bit and showed you in his presentation what does that look like. But here on the slide, you can see that for reference. So what does that mean? If we look at the patients who are coming from a non-thrombolysis ED to the ED of another center, we know there are situations that, when the patient arrives at that receiving hospital, their symptoms may be resolved and they may be discharged home as a TIA, or their symptoms may be resolved and they may be still require hospitalization and may be sent back as a non-stroke. So what does that sending hospital need to do related to the special projects? The sending hospital, because you're going to ED to ED, you would not, it's optional to complete it, but you can choose to do it for analytic and reporting. The receiving hospital, in the first case, if the patient was discharged home as a TIA, TIA is an applicable condition. So the receiving hospital would complete the 340, 640 in NACRS. If the patient was transferred back to the sending ED as a non-stroke, certainly it would depend on what the discharge diagnosis was to complete it. If the receiving hospital would complete the projects, and certainly the non-hospital would not complete because their applicable condition would not. If an inpatient is coming from those non-TPA hospitals and transferred to the thrombolysis ED, that the sending hospital would complete the DAD special project for a type 2 diagnosis. When the patient got to that receiving hospital, they're admitted for ongoing stroke care. The receiving hospital would complete 340, 640, and 740 in DAD. But if the symptoms resolve, it's not a stroke, they would be sent back to the sending inpatient facility as a non-stroke. In this situation, because the discharge diagnosis was not stroke, neither would complete the special projects. Steph talked about, we have models for endovascular therapy. In this situation, patients who are transferred from our thrombolysis hospitals are coming to the Hamilton General as a direct admit. They don't actually come to the emergency department unless they're unstable. And especially as our thrombolysis or telestroke sites are, because they're not coming from the ED, that sending hospital would complete 360 or 363. Let me just mix up the special projects all into one. 340 and 640 in the NACRS ED. When the patient comes to the receiving hospital, they may worsen on arrival and may be discharged back either to ED or the inpatient unit, and they're not appropriate for EVT. It would be the sending hospital would the sending hospital, because they're getting that patient back, would complete 340, 640, and 740 in the DAD abstract. If the patient is admitted to the Regional Stroke Center and undergo EVT and is either discharged from acute, that then the Regional Stroke Center would complete all of the special projects on the DAD abstract. As many of our EVT patients are, they would be repatriated back to their home stroke center. Again, in that situation, the Regional Stroke Center and the home stroke unit would complete the 340, 640 on their DAD abstracts. And just flagging, the sending hospitals would complete telestroke consultation in 640. When we look at other reasons patients may be transferred among is to access carotid revascularization surgery. And so this could be carotid endarterectomy or carotid stenting. 3 centers in our region provide carotid endarterectomy: the Hamilton General, Niagara Health, the St. Catharines Hospital, and Guelph General. The Hamilton General is the only hospital that performs carotid stenting. And so in this situation, the patient flow across our region varies with what and how patients may get to the carotid revascularization hospitals. So sometimes we know patients may be present with a TIA or minor stroke, are transferred directly from the ED to an inpatient bed at the carotid revascularization hospital. And so in this situation, the sending hospital would complete the 340 in the NACRS abstract, and the carotid revascularization hospital, if the patient's discharged home, would complete the special projects if the applicable condition is stroke or TIA. Sometimes at the carotid revascularization hospital, the carotid stenosis alone may be the admitting diagnosis with no mention of infarction or TIA. In this situation, the code would not qualify for the CHIM special project completion. We also know sometimes patients are admitted directly to the carotid revascularization hospitals as carotid stenosis alone. Again, the special projects would be completed at the carotid hospitals only if the applicable conditions were qualifying. Also, we know sometimes patients are transferred from acute to acute. Again, in this situation, the sending hospital would complete the 340, 640 in the DAD abstract. The receiving hospital would, again, it would depend on what that applicable diagnosis code is, the same as the previous example is. If there's mention of infarction or TIA, the project would be completed. If not, it wouldn't. And sometimes patients are either repatriated back again, they would complete it at the receiving home stroke hospital if the applicable condition is stroke. We also know, as Amy had flagged earlier, that patients may be transferred for tertiary level stroke care, so neurosurgery, neurocritical care, other neurointerventional procedures for hemorrhagic strokes, so coil aneurysm coiling, AVM embolization or gluing, or sometimes we know we have young patients or patients who require specialized tertiary level stroke care. So really, when we look at it, it really depends, again, where the patients are coming from. If they're coming from the emergency department, 340 and 640 would be completed in the NACRS abstract of the sending hospital. If the patient is discharged from the regional stroke center, the regional stroke center would complete 340, 640, and 740 in DAD. If the patient is transferred from admit to admit and then repatriated back, the sending hospital would complete the 340 in the DAD. The regional stroke hospital and the home stroke hospital would complete the 340, 640 in the DAD abstracts. When we look at repatriation, again, patients who are being repatriated back to their home stroke hospital or unit are going for ongoing stroke care and management. Recognizing that it can be challenging to find stroke symptom onset, thrombolysis date and time if the patient received it in the current visit, can lead to unknowns in completing those 340 fields. It is acceptable to look at the NACRS or DAD chart from that initial visit at your site before the patient was transferred out to enter that information. And certainly remembering if the patient received thrombolysis in the ED of your hospital, was sent out for endovascular treatment or tertiary level stroke care, repatriated back, thrombolysis will be considered prior at the receiving regional stroke center and also in the DAD abstract when the patient's repatriated. Steph talked about transferring patients for acute stroke unit care. And so talking about sort of what that looks like. So again, there are two situations which would depend on what that looks like. So patients may transfer from the ED of the community hospital. In those situations, the community hospital EDs completing the special projects is optional because they're going to an acute unit. If they're going from an inpatient unit at the community to the closest stroke unit hospital, the sending hospital would complete 340, 640 in the DAD. The receiving hospital would complete 340, 640, and 740 in the DAD. And then based on the disposition and discharged, they would complete the projects in the DAD abstract. Any quick questions before we move into case studies for this? Oops, sorry, I'm pulling up the wrong presentation. Okay, I'm not.
Just as you're calling that up, Rhonda, if you'd like to put up your hand, you can also do that, and you can ask your question that way if the chat or Q&A is not working.
Perfect. Okay, I'm going to move on into our case scenarios. And so again, you can see some of these are the similar cases we've used, but we're going to build on that as we go forward. So this is a, you can see it's a triage time at 9:09 at an Ontario telestroke site. The CT showed a right MCA infarct. The patient received thrombolysis. There is a telestroke consult note. The patient at 10:24 was transferred to an EVT hospital and received EVT. Post-CT, post the procedure at the EBT hospital, showed a right frontal lobe infarct in keeping with a right MCA infarct. There was a 2D echo completed at the EBT hospital, and the patient was repatriated 2 days after back to the home stroke unit hospital. So what, before I launch the poll, think about, would you complete 340 for this case? Would you complete it in the knackers, the dad, and I'll launch the poll. And I will minimize so that you can see if you need to see the case. I'll give it to maybe 140 and then I'll stop the poll. Okay, I'm going to end the poll and I'll share the results. So again, we have a bit of a mix. So 63 would complete it, 340 in knackers and dad. Then 21 would not complete it in knackers as the patient was transferred out. And 15% would say would complete only in the dad abstract. And so I'm going to stop sharing. I'm going to go back. And so in this situation, again, because patients are admitted from ED to acute, it would be completed in the knackers and the dad. The knackers, because they're going to admitted to acute, not going ED to ED, it would be completed in knackers and then in the dad when they were repatriated back. So would you code the telestroke consultation field in this? Would you code it in knackers? Would you code it in dad only? Code it in both knackers and dad. And I'll launch the poll. And give people time to respond. I'll give it just a couple more minutes. We're still seeing people respond. At 1:40, I'll end the poll. Okay, I'll share the results. So again, we have 77% would complete 640 in both NACRS and DAD. 11% would complete it in DAD only. 11% would not complete 640 because the patient was transferred out. So in this situation, this is an Ontario telestroke facility. And in 2022, there was the requirement that even patients who were transferred out should have it completed in NACRS. When the patient was transferred back, would be also completed in the DAD because there was a telestroke as there was going. Don't know if there's any comments or questions related to that. If not, I'll move on to the next case. Okay, so let's look at how would you code the NACR, or sorry, how would you code administration of acute stroke thrombolysis in the NACRS abstract? Would it be yes, prior, yes, prior, no, 8, not applicable? I'll launch the code or launch the poll. And let me know if you want me to go back. And bear in mind, this is in the NACRS abstract, just to be a bit confusing. I'll end the poll at 1:30. So again, you can see people would indicate it in the NACRS as yes. 12% would indicate yes prior. 10% would be no. And 5% it would be not applicable. Oh, did I share the results? All right. And I'll stop sharing. So in this situation, again, it would be considered yes in the NACRS abstract. How would we code it in the DAD abstract for thrombolysis in this case? And again, I'll launch the poll. So a similar but different. How would you how would you capture it in the DAD abstract of when the patient was repatriated back? We'll give people a chance to respond. I'll end the poll at 1:30, 1:30. Show results. So again, as we can see here, 74% said yes, they did receive thrombolysis, but was prior. 21% would say yes, and 6% would say no. So in this case, in the dad, it would be yes, prior. And this is where it's a bit confusing because it was in the NACR's visit at your facility. However, the patient was transferred out and then came back. So they did receive it, but it was prior, not during this episode of care. So I'll turn over to Debbie to talk about our second case as we walk through some of these.
Okay. So for case 2, the patient was brought to the ER by ambulance, tested COVID positive 3 days prior on December 25th, 21. They were triaged December 28th at 16:47. According to the EMS report, the patient was last seen normal at 13:30, reported that he experienced a headache at 1400, took a nap at 14:30, awoke 1 hour later at 15:30, and then fell from a chair and struck his head, sustaining no injury. The wife noted a facial droop at 1600, and some symptoms were improved or resolved at the time of this report. The telestroke consult states that the onset of symptoms was 2 days ago, December the 26th, where the patient awoke with symptoms, which was a headache, and again states 2 days ago. Experienced left hand and face weakness today at 14:30 on waking up. Symptoms are currently improved. It also states that the patient is not a candidate for TPA due to timelines, nor is a candidate for EVT due to the lack of intracranial large vessel occlusion based on the CTA results, and that they will be admitted to the stroke unit and maintained on ASA alone until it's determined if Plavix can be added for stroke prevention. The plan is to repeat the CT in 72 hours. The alpha film was scored on December the 30th, and dysphagia screening was done on December the 29th by speech language, which confirmed the diagnosis of dysphagia. The patient then developed decreased level of consciousness, and the CT identified an extension of that stroke with brain swelling. The patient was transferred out to a neurosurgery center for decompressive craniotomy on day 8. The meds on discharge state ASA was prescribed on.
I went too fast. Sorry, Debbie, I went too fast. I thought I moved and then I was like, oh, where am I at?
No problem. So the meds on discharge state ASA was prescribed on transfer back to the home hospital after a 7-day length of stay at the neurosurgery center. A new alpha film assessment was completed and the patient was admitted to low intensity rehab the next day. Then discharged from the home stroke hospital with a prescription for ASA as well. So for question, go ahead.
No, you go ahead.
So for question 5, which abstracts would you capture the prescription for antithrombotic on discharge, and what would you consider?
Okay, and I'll launch the poll. All right, sorry. Oops. We'll end the poll at 1 minute 30. And you can see the results here. 9% would do in the initial DAD, 32% went in only in the repatriated, and 58 would do it in both the initial and the repatriated DAD abstracts. And so again, Debbie, if you want to talk about what we'd look at and why we selected C.
Yes, the documentation states that patient was prescribed ASA on both the transfer and the discharge. So we would capture them both.
Steph, is there a question in the?
Yeah, just before moving ahead, are we able to go back one slide just for a second?
Yep. Oh, sorry. Oh, sorry. No, apparently I can't do that. No, I can.
That was the request from the Q&A.
Yeah. Yeah. Okay. I don't know if there's any follow-up questions with that. And then what we had looked at was how would we code antithrombotic therapy? Is it a yes, a no, an 8, or a 9? So I'll launch the poll, but then what I will do after I launch the poll is I'll go back to that slide for people. I'll move this over. Oh, sorry, every time I move it over, make it bigger. And we'll end the poll at 1 minute 30. Sorry, people started responding after I said I'd ended at 1 minute 30. So I'll end the poll. I'll share the results. So again, we can see 82% would indicate yes. They would code antithrombotic therapy. In this case, based on the ASA, 14% said no, 5% said not applicable. And so again, because of the ASA, we would consider that to, it is a yes. So then let's move on to 640, dysphagia screening. And would you code 640? How would you code 640 in this case? Yes, not applicable, or sorry, no, not applicable 8, or yes. I'll just launch the poll. And I'll go back. People need to see. I'll end the poll at 1:30. And sharing the results, again, 94% would indicate that they would code it yes. 6% would indicate it was an 8 as we're going. Sorry, as I move along. So again, in this case, there is the note in it that yes, the patient had dysphagia as we're going. We'll wrap up this case scenario looking at 740, so alpha FIM. And so what we're looking at here is how would you capture alpha FIM? Only in the initial DAD, in the repatriated DAD, or in both? And so I'll launch the poll and I'll go back to the slides for this one. Sorry, it's not looking like it's allowing me to launch, so we won't actually.
Rhonda, did you close the last question? Maybe that's why.
Maybe it's not. Did I not stop sharing? That's probably why. Thank you. So now do you see, so I'll go back to the cases. And I'll end the poll at 1:30. And so again, 62% said they would do it in both the initial and the repatriated. 15% would be in only the initial DAD, and 23 would do it in the repatriated DAD abstract. Sorry. And so certainly we would do it in both the initial and the repatriation. When we look at alpha FIM, the intention is it's done on day 3 on arrival to that facility. So it would be done initially when the patient was admitted and when they came back to be done as it would go to that site. I don't know if there's any quick questions related to that. When we share the slides, you will see there is how would you score alpha FIM in here. But just for the sake of time, I want to keep us on track. If there's no questions, I'll hand it over to Debbie to talk about some strategies for improving the special project data quality.
Okay. So strategies to improve data quality of the stroke projects, they can vary from site to site. And for those of you who attended last year's workshop, you'll probably remember some of these that were discussed. I'll just add a few more that are unique to Niagara Health. So the first thing that you can do is implement a tick-off sheet for the data elements according to the stroke project CIHI technical notes that could be completed by the stroke team. It would be placed on the chart pending approval to become part of the chart and be available for the stroke team to fill out. And it serves as a one-stop shop for the coders to get their information to complete the projects. I'm currently working with Leanne Kent here at Niagara Health to design a document that will help with consistency and accuracy for the coders. So we're looking to have that going in the next little while. The second thing you can do is if you don't have a completely electronic record like we do currently at Niagara Health, you can ensure those documents are scanned under the correct headings. It's a good idea to have any scanning errors and inconsistencies corrected. It's especially important as repatriated patients won't have an EMS sheet as a source document. Oh, excuse me, there's a page. Sorry about that. Yeah, the repatriated patients won't have an EMS sheet as a source document, and so onset of symptoms will be found in transferring hospital documentation. So basically ensuring that it's easily found and accessible under the correct heading in the chart is important. The next thing you can do is have dysphagia screening and alpha FIM results easily accessible in your HIS system. Niagara Health has a bedside swallow assessment that's documented in Meditech PCI, and alpha FIM is also documented there under assessment forms. And we also reach out to physiotherapy directly if there are score corrections that might be identified on the CIHI open year data quality reports. So we reach out to PT and they correct. And so that way we can update our abstracts to make sure that the scores are all within the correct ranges. Another thing you can do is carefully follow the CIHI project instructions, as you know. Ensuring you have a good understanding of the options. For example, when you're talking about administration of acute thrombolysis, understanding when to use 8, not applicable, when thrombolysis is given for another condition, or you have a hemorrhagic stroke as the diagnosis, or if the patient becomes palliative and thrombolysis is no longer being considered as part of treatment. Know who your stroke leads are at other sites in the region and connect with them for documentation issues and concerns. A list of these leads are going to be provided today in the post-workshop package. So that'll be a nice resource. Communication with your stroke team. We've mentioned that throughout this workshop. Know your physicians, your nurse practitioners, and who your coordinators are, and communicate any documentation requests for improvement or any questions to them. And that way they can be aware of what your documentation requirements are, and they can be proactive in helping to improve that. That's always, it's always an issue. We can always improve the documentation for sure. You can also work with your decision support team to ensure your data quality reports for month end and year end can correct errors before they get flagged on the open year data quality reports from CIHI. So that always helps. And another thing that was mentioned last year is you can link your WinREX abstract if you're a WinREX site. You can link the abstract to a stroke project whenever an applicable diagnosis is captured. And it was mentioned that 740 was linked because this was the most exclusive. It didn't have as many diagnoses. But it'll prompt the coders to add a project for all applicable diagnoses. So those are some strategies you can implement if you don't already have them in place. And yeah, it's always a process to improve. And I'll hand it back to Rhonda.
Are there any questions for Debbie? Okay, I'm going to be the last presentation and we'll wrap up. Sorry, I'm going to have to share and just find my last presentation. Oh. Sorry, I have them all at the bottom of my screen. Oh, there are future directions. I opened the wrong one. So just wanted to talk as we're wrapping up about some future directions in stroke care that we may see that may impact coding down the road. And I think last year I did talk about tenecteplase, maybe something that's coming through. And so we do see that, again, that's been something that is a very short period of time. And we've seen that change in our coding practices. So some of the things that I think you'll continue to see moving forward is, again, we may see changes with redirection from patients from the community hospitals with the paramedic screening for large vessel occlusion in 24 hours. We may be looking at it, improving efficiencies, expanding thrombolysis and EBT, and I'll talk about them both a little bit, all of those a little bit more very shortly. So as Steph said, the paramedics use the prompt card and they look at bypassing patients with stroke symptoms up to 6 hours from last known well. The paramedics also screen in the field with a tool called the LAMS for possible stroke, large vessel occlusion, so large vessel occlusion strokes eligible for EBT. It used to be up to 6 hours, and in March of this year, they started using that up to 24 hours from last known well. We know endovascular therapy patients are eligible for up to 24 hours, and so now the paramedics will screen up to 24 hours. Unfortunately, or as part of this initial change with screening the LAMS up to 24 hours, it's not changing where the paramedics go in the 6 to the 24-hour period. However, what we are working on is really to look at getting some sense of how many patients have a large vessel occlusion in that 6 to 24 hours. So working with the paramedic documentation and looking at situations is, can we change our destination protocols to say, if our paramedics have, and I'll use Niagara, and then I'll use an example in sort of the Hamilton area. In Niagara, if the patient's by St. Catharines with a large vessel occlusion stroke, it likely doesn't make sense to stop at St. Catharines General, and that should go, directly to the stroke center in GNGH where they can have their imaging. Similar, again, looking at sort of in, Haldeman, Norfolk, again, doesn't make sense stopping at Norfolk or Hagersville to then bringing the patient directly to Brantford General for where they could have then the imaging to determine if they're eligible for EVT. Similar in Waterloo, Wellington, and Wellington, not stopping in either Cambridge or St. Mary's or Fergus, Palmerston, Mount Forest, is taking those patients directly to those stroke centers. What we just need to do is get a bit of data to really look at what are the volumes of patients we're looking at. The other thing that we are really focusing on, because we know time is brain, is really looking at our processes to improve our door to needle. So you will see your sites working on that. And with our endovascular cases, again, to the first question at the beginning of the presentation to Steph, how long does it take patients from when they presented our referral hospitals to get to the general, is really looking at how can we quickly focus and improve the time they arrive at our thrombolysis sites to the time we transfer them out to our EVT center, and really looking at how can we best capture that door out time to inform our quality improvement, because it's something that is not documented well. And so we're really looking to say, how can we improve that door out time? What we also are always looking at is, are there ways that we can expand the inclusion criteria, and research ongoing related to thrombolysis? And so there are two trials. There are trials that are looking at giving tenecteplase to patients who have a more minor stroke, so an NIH of less than 5, which typically don't meet those criteria for thrombolysis. They have minor deficits, but they also have an occlusion in the intracranial arteries within 12 hours of onset. And so that study's ongoing. What we may see is expanding the number of patients that you're seeing coded with thrombolysis. And also, as Steph talked about, we have perfusion software. We typically use the onset of symptoms to look at time, how long we think that brain may be viable. What the perfusion imaging does is allows us to look at the perfusion of the brain tissue, especially in patients where the onset of symptom may be less well known. So wake-up strokes are unknown onset, because we know, though the patient woke with symptoms, their last known well may be when they went to bed. We know, though, that the stroke may have happened just before the patient woke up. And what our perfusion software does, using the artificial intelligence, is here, the pink area is the area of the brain that's dead. The green area is the area of brain that's salvageable. So it really allows us to time the brain to determine if there's salvageable brain. And so research is ongoing. You may see different imaging modalities, different types of patients, different onsets of last known well receiving thrombolysis if the evidence is positive. Lastly, again, you may see there's lots of evidence, because of how powerful the value of endovascular therapy is for our most severe strokes, is looking at expanding the eligibility, looking at patients who have lower aspects, or that their brain image, their CT scan is showing that there's more infarction in the brain, looking at patients who may have a low symptoms or more milder symptoms, but have a large vessel occlusion. We know sometimes that we don't know if it's safe to give endovascular therapy to patients who have a low NIH. We know sometimes patients may worsen when their collateral blood supply fails. So really trying to get some evidence to guide our practice, and understanding patients who have larger clots or clots affecting the internal carotid artery and the middle cerebral artery. What does that look like? So I don't know if there's any questions about what's coming down in the research, but certainly as evidence comes along, you'll see, as we saw with tenecteplase and the ACT trial and the changes to the best practices, you will see those changes made to the special project abstracts to really inform you of when that changes happen. So I'm not hearing, I'll quickly move along then as we're going. So as Steph said, we really value your feedback on the workshop. You can use your phone and click on the QR code. There is a link to the online evaluation. And Steph, did you put the link in the chat?
I have not yet. I'll go ahead and do that.
Okay, so the link will be in the chat. Also, when you leave the webinar, there will be a link to the chat. If you don't have time or you're not able to do it today, when you receive your link to the recording and the link to the presentations on the Central South website, you will have a link to complete the evaluation form. Please it's very quick to complete the evaluation form. We really value your feedback and made many changes to this year's workshop and expanded based on the feedback we received last year. So please take a moment to complete the evaluation form. Also, as Steph said, you will be sent a link to all of the presentations and the recording of the workshop. As Steph said, ideally, we'd like to send it out tomorrow, but certainly, if not, you'll get that link early next week. One of the things, so you'll have all of the presentations there. You'll also have the link to the presentation that Debbie talked about, that was resources to support completion of the CHIM special projects. So some of those tools, what are the inclusion, exclusion, the stroke symptom onset time. You'll also have a link to your stroke leads at your sites. Also, you'll have a link to the health information managers and directors across the region so that you can link for sites. This workshop, again, qualifies for 3 hours of your continuing professional development. When you receive the link to the webinar, you'll also have a link to request your certificate if you attended the live webinar session. I don't know if there's a chat in the question. Okay, no. So just want to thank everyone so much, one, for participating. It was so great to see over 107 participants from across our region. And I know some of our partners from healthcare. Certainly, we will, and please feel free to share the link to the recording and to the presentations with your colleagues who are not able to attend. I want to thank all of our speakers and our workshop planning committee, and also our health information manager coding teams from our sites who helped either with sending cases, who helped to answer my frenzied questions as I was preparing the presentations, reviewing the presentations. And thank all of you for participating in the presentation. Again, please share your feedback, any topics or learnings you would like for future workshops. As Steph said, when you are on our Central South Regional Stroke Network website, there's a link to lots of great presentations, more about hyperacute and endovascular therapy. There's links to anatomy and physiology. So certainly feel free, if there are other presentations of interest, feel comfortable to link on those and utilize the resources there. So thank you very much and have a great day. I see there's a comment in the chat. I don't know if there's a question. And Steph has just put the Central South Regional Stroke Network website in the chat. So thank you very much for coming and participating today. And we look forward to your feedback. Thanks for the feedback, Mary.